Okay, so good day, everyone. Welcome to our webinar on harm reduction, learnings from the European model. I am Berna Felipe, the ICU DDR coordinator for educational programs. And on behalf of the team, I would like to thank you for being here today. Just a few announcements. May I please request all participants to turn off their microphones during the presentation and make sure that it's off so as not to disrupt our webinar. If you have questions at any point, kindly use the chat box and our speaker will address them at the end of his presentation during the question and answer portion. Caleb and I will be monitoring that to make sure that your questions will be answered later on. So we are happy to have with us today a practitioner and researcher with extensive experience in training in social education, psychopedagogy, and psychology. For 15 years, our speaker have worked in the public mental health network, specializing in the care of young people and adults and the treatment of addictive behaviors. He also serves as a local reference point in the planning of various public health programs. He is an avid researcher accredited by the quality assurance agencies of the Spanish and Catalan public universities. He works as an adjunct professor of the University of Girona as well as the University of Barcelona and participates in several university master's programs. So, ladies and gentlemen, without further ado, a good friend of the International Consortium of Universities for Drug Demand Reduction, Dr. Fran Calvo. Dr. Fran. Okay, so let me just...
Hello, good afternoon. Thank you very much for your presentation. I will share my screen to share my presentation here. Okay. Can you see my presentation? Yes.
Yes, we can. Thank you.
Okay. So thank you very much, Berna and Caleb. It's a true honor and pride to be here with you delivering this seminar on harm reduction. Many thanks to the ICU DDR for the opportunity to contribute to the dissemination of scientific knowledge on harm reduction and also to the pedagogical development of practical experiences related to drug use, prevention, and treatment. Today, I have prepared a specific seminar on harm reduction associated with drug use. In the first part of the seminar, we will clarify some basic concepts on this subject. And subsequently, I will show you the main harm reduction programs at the European level. For this, I will provide some examples of harm reduction programs carried out in Catalonia, in Spain. Before becoming a university professor and researcher, I worked for over 15 years as a specialized social educator, something like a social worker in substance abuse. And part of my work involved working on the streets with homeless individuals, with individuals experiencing homelessness and severe alcohol users. And the other part involved working in environments where people inject drugs. In this later part of my work, the objectives of my functions were to reduce harm associated with drug use through intervention in open settings, meaning on the street, and also by coordinating a mobile harm reduction unit. I also have experience in training primary healthcare teams so that they could distribute syringes and other sterile materials to individuals in the general population who enjoy drugs. If it's agreeable to you, I will proceed with my presentation for approximately 45 minutes, and afterward we can open the floor for reflections or questions. etc. So I will gladly do so. As you already know, the phenomenon of drug use and addiction is very complex. Until now, it has been considered that the optimal organization of a territory in managing drug use, associated problems, and addiction typically involves these four axes: policies, prevention, harm reduction, and treatment. For example, policies on substance control, supply reduction, legislation encompassing national, local, municipal, regional levels, etc. This includes social and health policies at the territory, community levels, as well as clinical, social, and care-related policies. Prevention and its different levels: primary, secondary, and tertiary prevention, whose objectives may vary, ranging from attempting to reduce demand, delaying the onset of use, preventing risks and harms associated with use. Treatment for drug addiction when addiction already exists. Therefore, all actions in the different phases that individuals to go through: outpatient, residential, hospital-based treatments, individual, family, group therapies, pharmacological, psychological, social, community, etc., with the aim of achieving complete recovery, often based on abstinence from drug abuse. It's important to remember at this point that not all drug use is problematic. In fact, of the vast majority of individuals who experiment with or use substance recreationally through these lives, only a few will develop an addiction. As you will know, drug addictions are biopsychosocial mental disorders, and the social impact of the consequences of drug addiction is related to the social and cultural views on substances. For example, in a country where the consumption of a particular substance is culturally accepted, promote in various initiation rituals of consumption, and consumption is part of the daily life of families and communities, the psychosocial and community impact of its use is likely to be very different from when the same substance is prohibited or also frowned upon by one community. And finally, harm reduction, that following the definition by Marlatt formulated in the 19th, which we will expand on some issues in the next few minutes. This definition states that harm reduction refers to those programs, services, actions, institutions whose objectives is to minimize the harmful impact of drug use. Harm reductions acknowledge that the healthy situation for an individual is not to consume substances, but in the case of not being able to or not wanting to stop using them, they can receive biopsychosocial care to improve their quality of life. Therefore, when we talk about harm reduction, it should be noted that harm reduction is far from being the only approach, as it's combined with a strong offering of treatment oriented towards abstinence and prevention to avoid early use, dependence, and all forms of problematic use. The boundaries of these four axes are blurry. In other words, there are interconnect and even overlap at certain points. I believe it's convenient to explain these points of interrelation between the different approaches to addressing the phenomenon of substance use and its associated problems with some examples. And I believe it's convenient to explain these blurry boundaries because often discussions about the development of harm reduction policies or services become polarized, sometimes are very, very polarized. I'm sure that many of you have probably been part of or present in discussions about where on one side of the pendulum we have harm reduction, and on the other side of the pendulum we have drug-free programs proposals. But the reality, in my opinion, is that many cases the actual develop in intervention context provides an environment where these boundaries blur. I will give you some examples right now. Drug policies vary significantly from one country to another and over time. There are some common approaches that have been implemented. For example, prohibitionism. This is the most common policy in many countries where drugs considered illegal are prohibited in both possession and production distribution. This policy is based on the idea that the prohibition and penalization will deter drug use and reduce drug-related crime. There are a lot of examples of countries with these strict prohibition policies, included European countries, the United States, and many Asian countries, for example. The legalization, some countries have chosen to legalize certain drugs, so for example, marijuana or cannabis, for medicinal or recreational use. Legalization involves regulating the production, distribution, and consumption of drugs, often through licensing and taxation systems. Decriminalization. Instead of fully legalizing drugs, some countries have opted to decriminalize certain amounts of drugs for personal use. For example, this means that the use and possession of small amounts of drugs for personal use are not punished with imprisonment, although they may still be subject to fines of another administrative sections. For example, Portugal is a prominent example of a country that has decriminalized the use of drugs in small quantities. Regulation and control. Some advocates propose a system of regulation and control of the drug market similar to that used for alcohol and tobacco. This will involve legalizing and regulating the production, distribution, and sale of drugs, with the aim of reducing the risk associated with illegal drug use and eliminating the black market. This approach is being discussed in various places, but has not yet been implemented on a large scale. And harm reduction, this approach focuses on minimizing the risk and harms associated with drug use rather than simply punishing its use. It includes policies such as needle exchange programs for injectable drug users, supervised consumption rooms, and addiction treatment programs too. This approach has been implemented in several European countries, for example, in Switzerland, Spain, Netherlands, Germany, etc. It's important to note here that within drug-related policies, harm reduction may be found as one of these policies in itself, a policy with its own entity, although on the other hand, harm reduction, as we saw at the beginning, can be a central axis in the organization of the phenomenon within a territory. In terms of prevention, although different countries may have different terminologies, I believe we still all understand each other if we talk about primary, secondary, and tertiary prevention as different levels of prevention. Primary, secondary, and tertiary prevention are three key levels in the field of public health and medicine. For example, the primary prevention focuses on preventing the disease from occurring in the first place. Its main objectives are to prevent the disease before it develops and to promote overall health. Some primary prevention strategies include promoting health lifestyles, such as balanced diet and regular exercise, vaccination to prevent infectious diseases, health education programs, and the elimination of environmental and behavioral risk factors. The emphasis of this level of prevention is on avoiding exposure to risk factors and promoting healthy behaviors. The secondary prevention focuses on early detection and treatment of diseases in their early stage, before they become more severe or cause significant complication. The main goal is to identify the disease at an early stage when it's still treatable and may have a better prognosis. Secondary prevention strategies include conducting screening tests, for example, mammographs and colorectal cancer screening tests, etc. And finally, the tertiary prevention focus on reducing the impact of a chronic or persistent disease, as well as preventing the recurrence of complication and improving the quality of life of people who already have the disease. Tertiary prevention includes rehabilitation measures, management of chronic diseases, and palliative care. Interventions may include physical rehabilitation programs, occupational therapy, palliative care for terminally ill, and patient education of managing their disease to prevent relapses and complications. As we can see, tertiary prevention in substance use, could be identified with actions or intervention aimed at minimizing the impact of drug use when it's already occurring, which can also be defined as harm reduction too. In fact, many authors consider that harm reduction does not have its own entity, and that is simply another level of prevention. According to these authors, the primary difference of harm reduction is origin and emergence from the demand of drug users themselves with high socio-political involvement. Regarding treatment and recovery, we must consider that there is also an overlap with harm reduction. While it's true that much of the treatment offered for substance abuse has a drug-free approach, it's also true that many specific interventions within treatment services or programs have a harm reduction focus. For example, if we adhere to the trans-theoretical theories of change or motivational interviewing for the treatment of substance abuse, it's common for individuals in early stages of the process, individuals who are still using drugs that motivate the treatment, to receive advice aimed at minimizing harms associated with use. Therefore, harm reduction advice can be received within a treatment phase or fast or services. For example, in Europe, there is a strong adherence of treatment services to the trans-theoretical theories of change and motivational interviewing. This intervention framework indicates that even when the person does not want or cannot stop using substance, we, as professionals, can carry out actions that bring them closer to an improvement of their quality of life. Many of these actions involve the person improving the way they use drugs to minimize the possible impact of their health. An example of this could be a patient undergoing treatment for a cannabis-related disorder who increase their nicotine tobacco consumption when they stop using cannabis. A proposal aimed at total abstinence from tobacco in the face of a strong refusal from the patient may create some barriers to treatment. So an intervention aimed at trying to prevent this increase in tobacco or even trying to reduce the amount of tobacco smoked is aimed at minimizing the harm of this consumption. This is a common situation in many treatment processes and with many profiles of people with substance dependence, and it has shades and evocation of harm reduction. And finally, the harm reduction as axis of addressing the phenomenon of substance use and its treatment. We start this presentation by giving the Marlat definition, which we will revisit in a few seconds, but I think it's worth remembering some definitions commonly used. For example, the definition of the World Health Organization, set of activities that are intended to minimize the negative physical and include the transmission of HIV encouraged by the behaviors related to drug use. The definition of the harm reduction international that you can read, policies, program, practice that the aim to minimize the negative health, social or legal impacts associated with drug use. It's grown in justice and human rights. It's focused on positive change and on working with people without judgment, coercion, discrimination. This part of the social political issues that I spoke before. And for example, the National Institute of Drug Abuse interventions aim to help people avoid negative effects of drug use, but many understand harm reduction as a way to meet people where they are with kindness and respect. So I don't know if we will have time to see this video, so maybe I will advance with the next slides. I would like to span a bit of on the theoretical model on harm reduction proposed by Marlatt back in the 19th. In this well-known article titled Harm Reduction, Come As You Are, Marlatt invites us to reflect in 4 central points of harm reduction. In the first point, unlike proponents of the disease model, who view addiction as a biological genetic pathology and promote demand reduction as the primary goal of prevention, with abstinence as the only acceptance goal of treatment, harm reduction offers a wide range of policies and procedures designed to decrease the harmful consequences of addictive behavior. Harm reduction accepts the practical fact that many people use drugs and engage in other high-risk behaviors, and that idealistic vision of a drug-free society are unlikely to become a reality. In the second point, harm reduction is not against abstinence. Remember the polarized opinions, no? It's not against abstinence. The harmful effects of unsafe drug use or sexual activity can be placed along a continuum. Marlatt used the metaphor of a temperature range on a thermometer. When things become too hot or dangerous, harm reduction promotes lowering the temperature to a more moderate level, something like that. This gradual stepping down approach encourages individuals with excessive or high-risk behaviors to take it step by step to reduce the harmful consequences of their behavior. The ultimate goal of abstinence really reduces or eliminates the risk of harm associated with excessive drug use or unsafe sex. In this sense, abstinence is included as an ideal endpoint along a continuum ranging from excessively harmful to less harmful consequences. In the third point, needle exchange programs for intravenous drug users began in the Netherlands in response to the views of addicts belonging to the Junkie Bond group, who advocate for change in drug policies to allow legal needle exchange to reduce the risk of HIV infection. Many harm reduction projects reviewed in this paper originated at the local level often promote the grassroots advocacy by those directly involved in receiving and providing services. And finally, in the fourth point, street outreach programs provide an example of the low threshold approach to harm reduction. Instead of setting abstinence as a high threshold requirement or prerequisite for receiving addiction treatment for other assistance. Harm reduction advocates are willing to lower such barriers, thereby facilitating getting on board, getting involved, and starting. Low threshold programs do this through various means, reaching out and achieving partnership and cooperation with the population in need to develop new programs and services, reducing the stigma associated with seeking help for such problems, and providing an inclusive and normalized approach to high-risk substance use and sexual practices. Sorry. Let me use this picture of Homer Simpson to explain an issue that I believe it's of particular relevance in the more moral consideration of harm reduction. In Spain, it's estimated that more than the 80% of the diseases affecting the young population from adolescents, teenager to approximately 45 years old are due to poor habits. These bad habits usually include sedentary lifestyle, poor diet, alcohol consumption, and smoking, to name a few examples. These behaviors can also be transferred to many European countries. These behaviors are risk factors for many diseases. For example, let's take type 2 diabetes. In addition to the genetic factors of vulnerability to diabetes, the most important risk factors for developing it are related with these bad habits. Why do young people decide to eat unhealthy products like sugary products or soft drinks? Basically, it's understood to be for pleasure. Why do people decide to spend more time living on the couch, watching TV, and doing cardiovascular activities that improve their health? It's also understand that to be basically for pleasure. What is the reason of the health system when we have people to begin to show symptoms of health problems related to diabetes? Well, at certain levels of prevention, the aim is to minimize the possibility that people will develop diabetes. But when they are already diagnosed within, the aim is to minimize the impact of their behavior related to manage those pleasures on the disease. In this way, in addition to receiving medication aimed at balancing glucose level, for example, on the other hand, efforts are made for the person to eat healthier foods, learn and sometimes even cook healthy foods in a more attractive way. Efforts are made to limit sedentary behaviors and increase physical activity, and so on. In very few cases, in this behavioral usually judged or morally criminalized, no matter how harmful it may be to health or how far it may be from what is necessary from a good health. In other words, in the end, drug use is initiated to induce pleasure in people who use drugs. Them in the early experimental uses, the person experiences that positive contextual or pharmacological reinforcement, and in many cases decide to repeat the use. When a person already suffers from a drug dependence they deserve, just like in other diseases caused by behaviors that seek pleasure, healthcare that improves their quality of lives. Obviously, giving this presentation to an international audience presents the challenge of being able to show conference with the culturally accepted drugs in each society. And perhaps by giving the example that I will present below, I'm moving away from some cultural context, but I'm sure that the example I will give can be applied to other contexts with other substances adapt to the culture. In this case, I will give you the example of alcohol consumption. Alcohol consumption in Spain and many European countries is deeply rooted in culture and leisure time. Socially, there have often been initiatives aimed at reducing the harm associated with alcohol consumption that arise spontaneously in response to certainly associated harms. For example, in Spain, it's very common to attend cultural events such as music concerts. These concerts usually offer both alcoholic and non-alcoholic beverage. It's very common for many people to drink beer or wine or another alcoholic beverage and these concerts. In the 18th and 19th, drinks were served in glass cups. Considering that there was a high concentration of people drinking alcohol, this led to many glass cups falling to the ground in the concert environment, intoxicated individuals falling on the glass, people dancing, sleeping, and also falling on these glasses, and even potentially violent individuals using the cups to fight with others, and so on. These harms These are harms associated with alcohol consumption. Since alcohol intoxication, no matter how small, generates this disinhibition that is often associated with problems related with alcohol consumption, and that do not occur in other leisure environments where there is no alcohol consumption. In other words, in another leisure place like a library, there are no such problems because there is no alcohol consumption. A classic harm reduction intervention in many countries, perhaps we could even be talking about the first harm reduction intervention was to use the plastic cup in festive environments where alcohol was consumed. By using plastic cups, accidents related to the glass use ceased to exist. This proposal assumes that people who go to concerts will end up drinking both alcoholic and non-alcoholic beverage, and that the way to prevent the harms associated with this consumption is to use a least dangerous container. Sorry, I have a problem with my notes. Okay. So I want to go faster in this part. If you agree, I will now show some examples of programs and services that have demonstrated great efficacy and effectiveness in reducing harms associated with substance use. First of all, we can speak of the needle exchange programs operated by providing easy and confidential access to sterile settings for injectable drug users. Users can visit specific centers designated for this purpose, where they can exchange these use settings for new study loans, typically on a one-to-one basis or according to program policies. These facilities are often managed by public health organizations, NGOs, or other healthcare providers. The key aspects of the program are this one: confidentiality. Needle exchange programs typically operate under strict confidentiality policies to protect users' privacy. This helps to reduce fear of stigma and encourage more people to use the services without fear of discrimination. Education and counseling. These programs offer education and counseling on safe injection practice, risk reduction, harm reduction, disease prevention, and treatment options for addiction. This education and social education is essential to help users make informed decisions about their health. Referral to addiction services. These programs serve as an entry point to other health services, such as screening tests for infectious diseases, vaccination, addiction treatment, general medical care, and mental health services. This ensures that youth have access to comprehensive care and can address their health needs more effectively. And community involvement, it's crucial to involve the community in the design and implementation of these programs. The involvement of drug users and other community members helps ensure that the programs are culturally sensitive, tailored to local needs, and accepted in the community at large. And the impact and benefits of the programs are related to reducing the infectious disease, preventing the health complication, reducing the transmission of infectious diseases, access to sterile syringes, etc. In this picture, you can see the injection kit distributed by Public Harm Reduction Services in Catalonia, in Spain. In this picture, we can observe the contents of the kit. This is the back of the kit. With the program logo. This is the program logo of the sitting change program in Catalonia. Here we can see the sterile water used to mix dose of heroin, of cocaine. The sitting here itself sterilized. Further down, we can see the condom here, which is sometimes included in the kit. a little container to mix the substance with water, a small filter here, similar to a cigarette filter, to load the seating without loading it with harmful impurities that often appear in doses. And finally, a moist cotton here, a moist cotton pad with alcohol used to disinfect the puncture site both before and after the injection. It's important to note that the program's logo is recognizable to injection drug users, and when they encounter this sticker on the doors of pharmacies or primary health care centers, they identify that the service provides clean syringes for this exchange. This facilitates, people in identifying services where there are syringes. It's crucial because although the needle exchange program is called exchange, even if people don't bring dirty syringes to exchange for clean ones, it's important that people have access to injection materials. The World Health Organization considers that good coverage of needle exchange program should distribute 200 syringes per person per year. It will be important to add that the estimated annual cost to treat a person infected with the human immunodeficiency virus in Spain is 11,500 euros. The cost of treatment for a person infected with hepatitis C virus is more or less 8,000 euros annually. In contrast, the cost of a clean syringe is €0.5, which multiplied by the coverage of 200 syringes for the recommendation of the World Health Organization per person per year, the preventive cost of this intervention is about €100 annually per person. It's evident that we are facing a very cost-effective program with proven effectiveness in preventing these viral diseases. Here, more detailed explanation about the supervised injection facilities, also known supervised injection site or supervised consumption rooms or consumption sites, are controlled environments where individuals who inject drugs can do safely under the supervision of training staff. These facilities provide a clean and equipped space with sterile supplies for drug injection, as well as medical care personnel who can provide assistance in case of emergency. The key features of the assisted consumption rooms are the safe environment. Supervised injection facilities provide a safe and controlled environment for individuals to inject drugs. They are designed to reduce the risk associated with drug injection in unsupervised settings. Sterile supplies, obviously their facilities offer sterile syringes, needles, and other necessary supplies for drug injection. This supervised injection facility have training staff, including nurses, health counselors, social workers, or peer support workers who are available to provide counseling, education, socio-education on harm reduction. Another time, referral to health services. These facilities also serve as access point to additional health services such as disease screening tests, addiction treatment, medical care, and psychosocial counseling. And the benefits of supervised injection facilities related with the health risk reduction and the prevention of fatal overdoses. The trained staff in these facilities can intervene quickly in case of overdose by administering naloxone or other emergency treatments in safe lives. In these slices, we can observe some settings within a supervised injection facility in downtown Barcelona. Barcelona is one of the Spanish and European cities leading in the deployment of harm reduction services. In these facilities, individuals enter with their dose to consume inside. Here, they will find a safe place that allows them to consume without being exposed to the difficulties they encounter when consuming in public spaces, for example. Additionally, they will have the support of healthcare professional and social services that can help create environments for demand for intervention, aiming and improving their quality of life. Nursing staff often help find the best way to inject the substance without causing more harm than necessary. Individuals also have a quiet space where they can spend time before and after injection to rest in a safe environment. Often, individuals receive some coffee or caloric food item that allows them to better cope with their daily lives. Additionally, they can converse with others about things unrelated to the consumption environment. As we have repeated in other occasions, these environments are often the first step in a treatment towards recovery or basic abstinences. Another type of intervention carried out in harm reduction involves the creation of street outreach teams that work outdoors in environments where there is a big level of drug consumption. Open air or outreach teams, intervention teams, traverse these drug sales and consumption environments to offer people who inject drugs, injection materials, and also different benefits aimed at improving their quality of lives. These pictures that I'm showing was taken in a small neighborhood in Girona, one of the most important cities in Catalonia in Spain, just 80 kilometers from the border with France. It's one of the areas in Catalonia where there is the highest traffic and consumption of drugs in the north of Catalonia. One of the biggest community challenge in the fact that when injection material is distributed, neighbors consider that open air intervention teams and harm reduction are promoting the consumption. Many interventions by socio-educational teams are aimed at raising awareness of the importance of being able to offer community health services for this type of issues. Often these teams traverse areas like this I'm showing you. Obviously, these kind of pictures of situations make us more aware of the community impact of injected drug consumption on the street. For example, I said you that I developed this work as a social educator for 15 years, and my expertise tells me that by working with people in marginalized and consumption environments, you manage to get many of these patients in contact with health services that they probably will not have been to be able to do other ways. You can see here more pictures. And another kind of service are the mobile units. Often the intervention are carried out on the streets use satellite services from other leisure services, which are mobile units. A harm reduction mobile unit are equipped vehicles that offer a variety of health services and support to communities that may have limited access to traditional health services. These units are designed to move to specific areas where there is a high concentration of people who use drugs, including marginalized urban areas, rural areas, and other environments where medical care may be difficult to reach. This the key features of these kind of services are flexibility and mobility. The main characteristic of harm reduction mobile units is their ability to move and reach communities in need of care. These units can operate in places where access to health services is limited due to geographical, social, or economical barriers. These mobile units offer a range of harm reduction services, which may include needle exchange, infectious disease screening tests, such, for example, HIV or hepatitis, naloxone distribution, risk reduction counseling, etc., sexual health education, etc. These mobile units are generally staffed by a multidisciplinary team that may include healthcare professionals, social works, addiction counselors, and trained peers, individuals who have experienced drug use problems and have received training to help others, as you know. This staff provides personalized and empathetic care to drug users using the mobile unit services. So another program of harm reduction is the opioid substitution treatment program, and a harm reduction perspective, because the opioid substitution treatment is a treatment program, but it's a harm reduction program too. This program is an intervention that uses medications such as methadone or buprenorphine to address opioid dependence. From a harm reduction perspective, this program recognizes the importance of addressing the comprehensive health needs of people who use opioids, offering access to physical and mental health services, as well as social and community support to promote sustainable recovery. The primary focus of the program is on providing access to substitute medication that help reduce withdrawal symptoms and strong cravings for opioids, enable individuals to manage their addiction more effectively. In addition to medical care, comprehensive support is offered that address the physical, psychological, social, and emotional needs of people in treatment, including individual and group therapy, mental health counseling, relapse prevention services, safe housing, employment assistance, etc. From a harm reduction perspective, the program also focuses on mitigating the risk associated with opioid use, such as overdose and transmission in infectious diseases. Training is provided in the safe use of substitute medication, as well as overdose prevention and administration of naloxone to intervene in emergencies. Additionally, the program addresses social and environmental factors to contribute to addiction and its complications, offering social support, safe housing, employment assistance, and community resources to promote stability and well-being. And autonomy and self-management of individuals in treatment are promoted too, encouraging informed decision-making and control over their own health. Efforts are made to reduce the stigma and discrimination associated with opioid addiction, and the use of substitute medication, fostering a culture of understanding and acceptances. And another program, important program in Europe, is the Peer Overdose Prevention Program. The Peer Overdose Prevention Program is a harm reduction initiative involving people who use drugs to effectively prevent and respond to overdoses within their communities. These programs recognize that people who use drugs are often the first to witness an overdose and are well positioned in the community to intervene and save lives in these emergency situations. These programs participants in this program receive training in cardiopulmonary resuscitation and naloxone use training. These techniques and the use of naloxone and opioid overdose reversal medication. This training enables enables them to recognize signs of an overdose, administer first aid, and administer naloxone to reverse the effects of the overdose. These kind of programs often include free distribution of naloxone kits to participants. These kits contain naloxone in nasal, spray, or injectable form, as well as instructions on how to effectively administer the medication during this situation of overdose. In addition to practical training of CPR and naloxone use, these programs also provide education on the risk of overdose, signs and symptoms of opioid overdose, and how to prevent risk situations such as the drug combinations. The benefits of these programs is the reduction of overdose deaths. One of the most significant benefit of this program is their ability to reduce the overdose death by providing the CPR and naloxone in training to people who are at higher risk of witnessing an overdose, and have the characteristic of empowerment the community by empowering people who use drugs to respond to overdoses within their own communities. These programs empower individuals and promote a sense of solidarity and mutual care among peers. In Catalonia, Spain, the peer overdose prevention program has demonstrated high effectiveness in preventing mortality from overdoses among people with substance use disorders. And it's a highly integrated program in the provisions of specialized services in substance use disorders. It must be said that despite the demonstrated evidence of the effectiveness of these programs, their deployment is threatened by moral, political, and social issues. As we already know, although alcohol, tobacco, and cannabis use is more common and in certain environments more normalized than cocaine and heroin use, and may even cause more community and individual harm. People who use cocaine and heroin are heavily stigmatized, making it difficult for them to receive appropriate treatment according to specialized scientific evidence. I would like to take this remaining time to discuss specialized training in harm reduction. As universities responsible for training addiction specialists, it's our duty to provide them with a comprehensive spectrum of information and skills to perform their professional tasks. This obviously includes harm reduction. From our point of view, or my point of view, harm reduction should be considered part of our prevention activities. Prevention means avoiding an unwanted event considered harmful. The use of drugs may facilitate that harmful and unwanted events, especially when that use is repeated, among them death, overdose, social exclusion, dependence, family troubles, accidents, crime, etc. Dependence itself occupies a special position on this list, and it's a harm in itself that may further facilitate the occurrence of many other harms. It's important to highlight the difficulties we may face when teaching students about harm reduction. Firstly, attitudes, values, and prior beliefs related to their own consideration of drugs, their personal experiences, all of which result in a heavy moral burden. Another issue is the feeling that harm reduction is not successful because the person continues to use drugs and suffer many of their associated problems. For example, dependence. Furthermore, we encounter individuals who have themselves experienced addiction or have had family members who experienced it. In these cases, to alleviate their sense of guiltiness about themselves or their loved ones, all blame is attributed to the substance. No compromise with evil is then possible. The harm reduction approach may be a danger to their potentially functional constructs. Professionals in the health and social sector like to cure, to save, to fight, to eradicate. Also, politicians and the media favor this commitment and absolute words. But often the true best available option is just to improve, to keep alive, to achieve the best possible outcomes, to decrease harm, and to alleviate. In this environment, how can we improve training in harm reduction? I think that first is necessary to change the mind of the students, changing minds in the sense that there are no absolute or polarized reasons. The first approach that many students have often undergone has been black or white, yes or not, good or bad, desired or unacceptable, praised or zero tolerance. We propose a training environment based on open, careful, and respectful debate to try to accept that people, in exercising their freedom and decision-making capacity, may not be able or willing to quit the drugs. This includes 50 hours of face-to-face teaching in harm reduction in the Master of Barcelona, in addition to visit to specialized harm reduction services in the community. And finally, the placement within the second year, a minimum of 300 hours, may be full-time in a harm reduction program or facility according to their choice. The master thesis could also deal with harm reduction if they choose a subject with this area. In our experience, the harm reduction module was included in the curriculum of the Master of the University of Barcelona starting in 1987, the year 1987. Initially, it received many hard criticism for not being anti-drug, enough anti-drug. It should be noted that almost all of our former critics are now strong supporters. We advocate addressing the issue even though in its continuous respecting the diversity. I want to take this opportunity today to reiterate that many of the health problems we currently face are due to bad habits, and ultimately all these bad habits have to do with the inherent difficulty of humans to manage their appetites and pleasures. In the end, harm reduction aligns with other well-integrated health actions, such as dealing with people who eat inadequately, do not exercise, engage in risky sports, and so on. Well, I hope you found my presentation interesting and that I have been to be able to contribute to the reflection on the need to include harm reduction programs, actions, and intervention in the proposal for addiction services. I'm not sure if we have much time for question or comments, but in any case, here my email address. If you want to contact me for anything that you want, don't worry, please write me. Soon we will have the ICUDDR Congress in Greece this summer, and I hope we can see many of you there and exchange opinions and impressions about our work and experiences. So thank you very much for your attention, and very sorry for my English limitations too. Thank you very much.
No. Thank you, Fran. You did great, and we do have time for about 2 to 3 questions. Let me begin by reading our good friend Carol's comment and then her question. So Carol mentioned about how many people confuse harm reduction as a route to abstinence rather than a person-centered intervention which is guided by the client themselves. So that's her comment, and her question is, if you actually distribute drug testing strips in your program.
Yes, we have in the there are some programs in Barcelona, in Catalonia, in Spain that distribute this kind of test to try to have more information about the quality of the drugs in the moment that the people decide to consume these drugs. Yes, we have these kind of programs. One of the most important is energy control. The name of the program is energy control, and they go to the places where people want to use the drugs, festivals, concerts, etc. And they offer the possibility of to know more about the different substance that people want to consume. Yes, we have these programs.
Okay,
Have
thank
these
you for that. And then there's another question with regards to, do you guys use the distinction between medicine and drugs?
Sorry, and the question is, sorry?
If there is a difference or distinction between medicine and drugs.
Uh, mm, it depends of the use of the words in each country and culture. I think that we don't have this distinction in Spain, for example, because drugs are substances that have an effect in the central nervous system. Some of these kind of substances can be used by some kind of treatments, and are very common to use in treatments for some kind of diseases. So we don't have this difference in Spain, but I think that in another countries you have this difference.
Oh, yes, we do. Like if I may add to that, like in some countries, there's a connotation with regards to drugs being illegal or illicit, while medicine are so supposed to be curative. But you are right. There's supposed to be scientifically, there's no difference with regards to it. Both have effects. We can use medicine or psychoactive drugs as the terminologies, but it's more of a cultural thing. So thank you. And then there's a lot of comments about how they wanted to advocate for harm reduction in their countries, such as Nigeria and other places. But what I love most about your presentation is how you talked about how harm reduction is polarizing, right? And
Yeah.
that's very true in a lot of countries. Um, I think that's about it. A lot of them are saying thank you
I
with
think sorry,
oh.
Bernard. I think this issue that you mentioned is very important because we can integrate a lot of actions in harm reduction in context of treatment or prevention. And yes, I think that's polarizing. Sometimes it's not very useful for the practical of the day of each day. Sorry, please.
No, no worries. You're good. There's another question. If you have a short course at the university on overdose prevention program.
Mhm.
So do you have a short course or it's integrated into the master's degree program on overdose prevention?
Yeah, the overdose prevention program is a educational program for people who use drugs, but we can offer this program from the government of Catalonia for all people that works with people who have problem of drugs, and the professionals could make this kind of courses. It's a free course to attend the overdose problems of people that are in treatment services or residential services. So yes, we don't offer directly in the masters of in the university, but if you are interested in do this kind of courses, you can do it in the for the health government of Catalonia, Spain. Yes.
So I think you have emphasized another important aspect of understanding harm reduction from the perspective of the academic community, the
Yeah.
civil society, as well as the government, right? And
Yeah.
then this would be our last question, and this might be a little bit challenging. The question is, how would you encourage harm reduction in cultures that may not believe or support harm reduction?
Uh, I don't know. I think that we need to. Sorry with my English limitation. I am so sorry. We need to make little goals every day, trying to sensibilize the importance of the human rights related with these goals, scientifically demonstrated by the harm reduction approach. And I know that is hard or very difficult in some places. Here in Spain, for example, we have communities, places, territories that they don't have any harm reduction program because they don't want, and it's very difficult for us to try to be convincing to develop it. So I think that it's very important to do a lot of community work, street work, trying to sensibilize the local leaders, the municipality leaders, and yes, and do this work from the base of the society. I don't know if I answered the question. It's very difficult to answer this question. Yeah.
Yes, and you are right, but you're correct in two things. It's challenging, but we can all do a little bit of something, right?
Yeah.
So either through advocacy, and you mentioned a little about, how our attitude, knowledge, and behaviors actually shape a lot with regards to the implementation of any programs, any services. And like you being here, like our audience, I think that's one step, right? Understanding what it is, trying to know about the, like, from the scientific perspective. So with that, we would like to thank ICU-DDR, would like to thank our good friend Fran. Thank you so much for sharing your expertise, and to everyone for attending. So to know more about our upcoming events, please follow our Facebook page, as well as visit our website, www.icuddr.com. We have two webinars scheduled on April. One is on inhalants, and then the other one is with the Phoenix European Union project on quality standards. We hope to see you. Again, Fran, thank you, and I'll see you in
Thank you.
Greece. Have a good day, everyone.
Bye. Thank you very
Goodbye.
much.
Thank you.